Okay, so before the refreshment break, we'll do a little metabolic review. Oh boy. Everyone's least favorite subject. I'll see if I can make it simple and digestible for you. So if you start with one of those dictionary definitions of inborn errors of metabolism, you can say, it's a biochemical disorder caused by a genetically determined defect in a metabolic pathway, yada, yada. And immediately you go right to sleep. We will not allow that to happen this afternoon, okay? You think about these diagrams with all these arrows and stuff going which way and backwards and upside down, and oh, it looks like the line of scrimmage here, and once again the quarterback of the Cleveland Browns is sacked behind the line of scrimmage. Oh, are we bummed out? Don't think about it like that. Think about it like this. Okay, forget the Cleveland Browns if that's humanly possible, and think about the ABCs of inborn errors of metabolism, okay? This is basic chemistry. You start off with a starting material, we call that a substrate. What do enzymes do? They convert one compound into another, okay? So these are sequential enzymatic steps, these horizontal arrows. And what might happen if you have a deficiency in this enzyme here that converts A to B? Well, the starting material is going to build up, and everything downstream is going to be decreased. It's that simple. Okay, you can take a break now. Okay, stick around, I'll tell you some more. All right, so that's the basic defect in most inborn errors of metabolism. Now, there's more than one way to metabolize some compounds. And your body has many of these different ways to choose from. So this may be the preferred pathway, but let's say that there are enzymes that exist that can decrease this amount of A and turn it into some different compounds. Okay, getting rid of this buildup. Good idea? Sometimes, not always. What if A is phenylalanine, a very noble amino acid? One of my favorite amino acids. It's great, it's huge. And this enzyme is phenylalanine hydroxylase, which converts phenylalanine to tyrosine, which is an important amino acid as well. Well, when you are missing or have a deficiency in this enzyme, your body can take an alternative pathway and turn phenylalanine into phenylactate and phenylpyruvate. Good idea? Bad idea. Phenylactate and phenylpyruvate are phenylketones, and phenylketones are neurotoxic. Bad idea. But if you have this genetic condition we call Phenylketonuria, you don't have a choice, and your body makes this choice all by itself. And that is the crux of treatment, is to recognize the pathway and figure out how to get around that blockade, okay? So that's what we're going to try and do. Now this slide is just sort of a catalog. It's not meant to intimidate, although it sure does. You're not supposed to memorize all these inborn errors of metabolism on here, but it serves to illustrate mode of inheritance. If you have to guess the mode of inheritance of an inborn error of metabolism on a board exam, it's most likely autosomal recessive. Those are not labeled. The ones that are labeled are the exceptions, and most of those exceptions are X-linked. So we have ornithine transcarbamylase deficiency, which is an X-linked urea cycle disorder. We have Fabry's disease, which is an X-linked lipid storage disorder. We have Hunter syndrome, which is an X-linked mucopolysaccharidosis, and so forth. So those are the exceptions, and there are only 5 of them up here. So if you want to memorize something, you could do that. But the idea here is, when I consider an inborn error of metabolism in a child, I look for the symptoms that would best fit one of these categories of metabolic disease. And then I delve into those and see which, if any, fit. Okay? Now, just as a reminder, I know in the very first lecture I gave, I didn't review the basic tenets of genetics, like modes of inheritance and that sort of thing. This is autosomal recessive. Both parents are carriers. They have a good copy of a gene and a bad copy of the gene. And there's a 25% chance of having an affected child, 25% chance of having a child who inherits neither abnormal allele or copy of the gene. And then half their kids will be carriers just like the asymptomatic parents. Okay, so 25% chance of having an affected child, autosomal recessive, you got it. So whether this is PKU, an inborn error of metabolism, or sickle cell anemia, a disorder of hemoglobin synthesis, or cystic fibrosis, a defect in the CFTR gene, they're all autosomal recessive in their inheritance pattern. Okay, how do inborn errors of metabolism present? Well, the most serious types will present as metabolic disease of the newborn. This is true emergency situation. They may present gradually over time with perhaps organomegaly or loss of milestones. They may present as an ill-defined chronic failure to thrive, or rarely mental retardation with no other manifestations. Or they may be relatively late onset or considered benign. And in this category, I would put hypercholesterolemia, which is a genetic defect present at conception, which usually doesn't present until 40s or 50s or 60s, okay? So a lot of these conditions, but certainly not all, can be picked up by newborn screening. So there's a little more extensive discussion of this in your notes. In the old days, what was available in newborn screening was a pretty short list. It was often referred to as the PKU test, because that's the only one anyone could remember. The others including galactosemia, hypothyroidism, and the hemoglobinopathies, and gradually congenital adrenal hyperplasia. The expanded list includes amino acid disorders, organic acidurias for the first time, fatty acid oxidation defects, one urea cycle disorder, and at least in California, a DNA-based test for severe combined immunodeficiency. So not exactly what we would consider an inborn error of metabolism, and the only newborn screening that's done using DNA rather than biochemical metabolites. So for those of you who haven't had the opportunity to see what the samples look like, the important part is the paperwork. Fill out the paperwork properly or the state will send the sample back and say it's invalid. It's done using dried blood spots because the tests that are employed do not measure unstable compounds. So a dried blood spot can be tested 10 or 20 years later with the same accuracy. So that even a Simpson can figure this one out. And the testing is now done by mass spectroscopy, so all these tests can be done in the same machine, except for the hemoglobin screening. So this is a tabletop-sized machine which prints out a series of peaks, and then some very smart person or computer will solve the puzzle and see if things are normal or abnormal. So, with that introduction, let's talk about a couple textbook cases, a couple real-life cases, and go from there. So this is obviously a textbook case. I think if you flip through some standard textbooks, you know where this came from. This is a 3-week-old male with jaundice. See the jaundice? He's jaundiced, okay. Hepatomegaly, this is the outline of the liver. Diarrhea, failure to thrive. Flunked a newborn screen for something, okay. Well, that something is galactosemia, okay? Because the galactose metabolites that are not processed properly are toxic to the liver. Hence, you get liver failure, you get jaundice, and that's the basis behind galactosemia. So the screening test measures galactose and also measures the galactose transferase enzyme. These days, we don't so much need a dietary prerequisite, so these tests are so sensitive that even a child who hasn't had his first drop of formula can be tested. If it is undiagnosed and untreated, these kids present as the one in the textbook with the jaundice, the large liver, hepatic dysfunction. They're predisposed or susceptible to E. coli sepsis and may result in early death. The treatment is trivial. Is to remove galactose and lactose, which is a disaccharide containing galactose, from the diet. It's very straightforward. But you have to diagnose it first. So, case in point, several years ago when I was back at Vanderbilt in Nashville, there was a child who presented to our emergency room at 1 month of age who looked like the kid in the slide here, and had apparently failed his newborn screen for galactosemia, but the state was unable to contact the family. Perhaps they took the child out of state to visit relatives, or their phone got disconnected, or something. Anyway, this child couldn't be tracked down in the first month of life. And he was admitted to our ICU, and he died of DIC because he wasn't caught in time. So there's an example of a perfectly preventable disorder which resulted in a death because of the inability to communicate with the family. So again, making the point, whoever's responsible in your organization for filling out those newborn screening cards, put down as many phone numbers as you can, because if something is awry, somebody needs to contact the family, okay? So here's an example of a healthy, thriving child who was picked up on a newborn screen, was immediately started on a special diet, and he's happy as he can be, but he knows better than to drink cow's milk. Another textbook case, a 10-month-old boy with developmental delay, fair skin, blonde hair, see the blonde hair, and he totally missed his newborn screen for something, so it was never done in this particular case, as the story goes. Well, he has the same condition as this guy who was picked up on newborn screen. This is a kid, I took this picture at 18 months of age, but I met him when he was a newborn because I was on call for the metabolic service that weekend, and I get a call from the state newborn lab at 5 o'clock Friday afternoon. Okay, Dr. Taylor, we have an abnormal newborn screen for this child. Okay, so I call the family and I get an answering machine, and I call the pediatrician and I get an answering machine. But I leave callback numbers, and after I've cracked open my first beer for the evening, the family calls back and says, "We're returning your call." And I said, "Hi, your child had an abnormal newborn screen. It's probably not an emergency, but if you've got nothing better to do, our clinic's closed, but you could come down to the emergency room if you want to." And they were very upscale parents, and they said, "Yes, we will meet you in the emergency room." So I talked with them about the abnormal screen, and I put the child on a special formula, and I said, if this is a false positive, we'll know Monday afternoon. You can take the special formula and throw it away. If, on the other hand, your child does have PKU, he will already be on the special formula, and we'll just have a counseling session on Monday. Sure enough, my suspicions were true, and he did indeed have PKU, and his family was very compliant with his diet. And you can see here at 18 months of age, he's happy, he's healthy, and he's cruising daycare picking up chicks. So, life is good. Life is very good. So it's the most common amino acid disorder. The screening test is to measure phenylalanine, the amino acid. The prerequisites are not so important anymore. The diagnostic test is to look at all the amino acids, okay, because we can see that we should see phenylalanine to be elevated, and we should see tyrosine, which is downstream from the block, to be decreased. So that adds an additional confirmation. If we don't recognize and treat PKU, it can lead to moderate severe mental retardation, autism in some, even seizures, and hypopigmentation, because even further downstream from tyrosine, as you'll see in the last lecture, there are some metabolic pathways that generate pigments. So if you have PKU and it's untreated and you're not supplemented with tyrosine to get around that blockade, then you can't make certain pigments, and you're fair-haired and fair-skinned. The treatment is a lifelong dietary restriction on phenylalanine. So this means low protein, especially proteins that are higher in phenylalanine. And years ago, we used to think that, well, once brain development is finished, you can eat whatever you'd like. But that's not exactly the case, because we have found even in adults who stray from the diet, they may get a little dull, they may get a little irritable, they may lose a few IQ points each year. So they're really much better staying on the diet lifetime. And that requires a lot of dedication and it requires the help of a nutritionist or dietitian who helps the biochemical geneticist maintain compliance with that diet. So here's a typical plasma amino acid profile from a plasma amino acid analyzer, and each one of these points is a different amino acid, and they have different mobilities in the machine. And I think it's not too difficult to figure out that this might be the abnormal spot here. And I happen to know that spot number 17 is phenylalanine. Somewhere in here towards the bottom end of the spectrum would be tyrosine, which is below the normal range, this being upper range of normal, this being lower range of normal in green. So this is a way to not only make a diagnosis, but also to see if there is compliance with the diet. That's PKU. This is a 17-year-old girl who I met at that age, who by history presented to medical attention at age 5 with acute eye pain. So why did she have acute eye pain? She had acute eye pain because she had acute glaucoma. She had acute glaucoma because she had a slipped lens in that eye, which slipped downward and occluded the canal of, don't let me down now, the canal of Schlemm. Why did we waste a neuron to memorize that? But yeah, it's the canal of Schlemm. Poor guy. Anyway, so ophthalmologist picks up on this and either extracted or repositioned the lens and sent this girl to genetics at age 5, where she was diagnosed with homocystinuria. Okay, so here's a slip lens, which belongs in the center of the pupil here. And this is that girl's growth curve. So you can see from a younger age, she's always been into 95th percentile in height. So what's your differential diagnosis for ectopia lentis and tall stature, homocystinuria, and Marfan syndrome? Okay, very simple. So that's your differential. So homocystinuria, not very common. And as the name implies, there's increased homocysteine in the urine. But do we use urine for newborn screening? No. We use blood. Well, as it turns out, there is homocystinemia also, technically. But homocysteine is an unstable compound. So if you take a blood spot or even urine and you abuse it or don't keep it chilled properly, that homocysteine is going to break down and disappear. So all your testing will be false negative. So instead we measure methionine, which is a very stable amino acid, and we can measure that on a dry blood spot. And if that is elevated, then we have a clue that we're dealing with homocystinuria, and I'll show you why in a minute. Untreated, these kids are tall, they may be at increased risk for scoliosis, they may be at increased risk for osteoporosis and hypercoagulability. We had a teenage boy we followed at Vanderbilt for several years, and one day he just decided to stop taking his medication, and he developed a deep vein thrombosis and was hospitalized. He learned his lesson. He was compliant from that point on. There's several different drugs you can use to treat homocystinuria. Betaine is probably the most common, but don't forget the aspirin, low-dose aspirin for anticoagulation. So here's an amino acid profile of excuse me, of an individual with homocystinuria. And this is methionine. It's practically off the page. And this is homocysteine down here. Okay? Now, methionine is non-toxic. And methionine is a product of conjugating betaine with homocysteine. So we like this pathway. So this is an alternative pathway to keep the homocysteine at a very low level, because the normal level is 0. And this is about as close to 0 as you can get. And we don't care how high the methionine is. So this tells us that the patient is indeed compliant taking his betaine because the methionine is so high. So not only can we use this lab result for diagnosing, but also to measure compliance. Okay, so again, a simple diagram showing where the defect is in homocystinuria and how homocysteine can build up and how betaine takes you back up to the very non-toxic methionine, which can be used in other pathways. Okay, there you go. So let's take a gander at metabolic disease of the newborn for a moment here. We know that inborn errors of metabolism are individually rare, 1 in 50,000, 1 in 100,000. So why do we bother screening for them? Because collectively, they can have a significant burden on our population. The symptoms are usually nonspecific, but if you delay the diagnosis, that can lead to irreversible end organ damage, brain damage, liver damage, other organ systems. So that's why it's important to screen for them, and many of them are treatable. So when should you suspect an acute metabolic disease in infancy? Perhaps a family history of unexplained neonatal deaths. We had 6 kids and they all died of sepsis. Don't think so. These kids are healthy for hours or days for the most part, and then these nonspecific symptoms kind of sneak in. So they may feed poorly, they may have vomiting, they may have lethargy, they may lapse, frankly, into coma, they may have seizures, they may have peculiar odors. So occasionally we'll get a nurse in the newborn nursery or the NICU that says, this baby just doesn't smell right. Or we'll have parents who say, we bathe our baby twice a day and the baby still smells like dirty sweat socks. That may be a clue. Or unexplained metabolic acidosis. So these are all conditions that make us suspicious. So what is readily available to you in addition to the newborn screen? Well, we can look at a CBC with the different platelets. We may see thrombocytopenia. We may see neutropenia. We can look at a serum glucose to see if there's hypoglycemia. We can measure lactate and pyruvate to see if those are increased. We can look at electrolytes to see if there's a metabolic acidosis. We can measure ammonia to see if we may be dealing with a urea cycle disorder. And we can look at the urinalysis for reducing substances and ketones. So these are cheap, readily available. You get them back in an hour or two. So if any of these are abnormal, then we have additional suspicion. And then we may elect to go to the next step and do some more esoteric types of tests, which take a little bit longer. They may take special processing. They may not be available in your institution, such as plasma amino acids, urine organics, very long-chain fatty acids, and other things, even specific enzyme assays. Some of all this can be precluded by the newborn screen, and as I said, other disorders are not amenable to the newborn screen. So let me briefly introduce this algorithm, which is in your notes, of a child with metabolic acidosis and how you work through this algorithm with very simple analyte measurements. And just to make a long story short, for example, you could take a child with metabolic acidosis who has an increased anion gap and some hypoglycemia and maybe a pinch of hyperammonemia and no ketones in the urine despite hypoglycemia, and you're down here in the area of fatty acid oxidation defects, like MCAD. So that's how this algorithm can help you out. So MCAD, if you need to know one defect in fatty acid metabolism, this is the one. Autosomal recessive, predisposure to hypoglycemia, and you can see hypoglycemia without ketones in the urine, okay? And an abnormal acylcarnitine profile. Now, in this day and age, an acylcarnitine profile is part of the newborn screen done by mass spectroscopy. The defect here is in metabolism of medium chain fatty acids, and the treatment is very simple: frequent feeding to prevent hypoglycemia and carnitine to bolster that pathway. So here's the pathway, very simple. We know that fatty acids are broken down into single chain fatty acids. They are conjugated with acyl with CoA, and then they make it into the mitochondria where beta oxidation takes place. That entry point requires carnitine. So if this portion of the metabolism is crippled, you want to push this forward as much as possible. So you can bolster it a bit by supplementing with carnitine to push this side of the reaction. Because most inborn errors of metabolism are not absolute absence of an enzyme activity. They are a relative absence, not a complete absence. So whatever activity is residual, you can force it forward with some of these cofactors. So that's the idea to keep in mind. This is your mitochondria. Any questions? No. Okay. I like you too much to go through this. But let's talk about urea cycle disorders, okay? So urea cycle disorders may present at any age, but most commonly in the newborn period. These kids are normal for a few hours to days until the ammonia builds up, okay? That toxic substance. And then they can lapse into coma. They may hyperventilate to try and blow off some of that ammonia. They may be hypothermic. And here is a case study here. This little girl here is our subject. She's sitting on the lap of a genetic counselor. Mother's not in the picture. This is our dietitian, and this was my intrepid colleague at Vanderbilt who helped diagnose her. She was born down in Chattanooga, and at about 8 to 10 days, maybe a little younger, presented to the Children's Hospital down there in coma. She was life-flighted up to Nashville, admitted to our PICU, and we were consulted, and one of the first things that we noted was she had marked hyperammonemia. So that prompted my metabolic colleague here to deal with that. We suspected a urea cycle disorder, so we ordered a STAT, plasma amino acid profile, but had to deal with this hyperammonemia because we got a CT scan on this kid, and she had cerebral edema, and she was herniating her brain right in front of our eyes. So what do? How do you lower an ammonia as quickly as possible? You give lactulose? No, not going to do it. Peritoneal dialysis, that requires a surgical procedure, too slow. Hemodialysis, not in a newborn because you can't get adequate vascular access to make it happen quickly, unless you put the kid on ECMO. Good idea. New England Journal of Medicine. So, brilliant idea. And within 45 minutes of being hooked up to ECMO with a hemofiltration machine in the circuit, the ammonia plummeted, and she woke up. Saved her life. Now, why did she have this particular urea cycle disorder? Well, here she is on a pedigree. Here's her mother, who was reluctant to tell us who the father was. Mother was 16. And eventually we figured out that the mother was also the grandfather, was also the great uncle. So we have not one, but 2 generations of incest here. Very unfortunate. We're hoping that this character is behind bars now. So this illustrates the occasional incidence of consanguinity leading to an increased risk for an autosomal recessive disorder. Just saying. So how do we treat these urea cycle disorders? Well, number one, there are actually 3 categories to contend with. One is to prevent protein catabolism or protein breakdown, because that's how we make waste nitrogen. So you want these kids to be well fed, especially when they're ill. And we may need to supplement them with arginine because arginine is usually not an essential amino acid, but when you have a defect in the urea cycle, it becomes an essential amino acid. So prevent protein breakdown. Number 2, decrease the ammonia load. So normally you restrict the protein in the diet to the amount that's needed for growth and not go over that. And thirdly, utilize ammonia scavengers. So these are some compounds that help bind actually to glycine to lower the ammonia and the nitrogen load in the body. And one of them happens to be a food preservative, so at your break, when you're taking your snacks, you may be getting a little sodium benzoate in your snack food there. So this is the 3-pronged approach to treating urea cycle disorders, which can be done fairly successfully. This is a little guy who's grade school age now, but he's not doing particularly well in school. He presented prenatally, if you will. So how can you present prenatally with an inborn error metabolism? Mother was healthy. Well, in the 3rd trimester, towards the end of the pregnancy, he was having hiccups. And hiccups are kind of amusing, except to a geneticist. So the family thought it was amusing that you could put your hands on mommy's belly and you can feel the baby hiccup. Okay. Well, that was okay. And then he was delivered, and he was still hiccuping on occasion. And that was still amusing until he started seizing, and that wasn't so amusing. And then he went into coma. And that's what got him to our attention. So this evolution from hiccuping to seizures to coma points to a condition known as Nonketotic hyperglycinemia. And this child had several episodes of coma in the first year of life, and you can see here he sustained some brain damage because of that. So he's a little bit spastic and he's developmentally delayed. So why do I include this very rare condition in our lecture here? Because it started off with what was perceived to be an innocent symptom. But to the trained specialists, that is a warning sign. So this is another recessive disorder. This is the typical clinical progression in the first few days of life. And it can be measured by plasma amino acid profiles, so it can be picked up on newborn screening. It's a defect in breaking down glycine, which is a very neutral amino acid. And again, we can use these sodium benzoate scavengers, which bind to glycine and get rid of that excess ammonia so that this process doesn't continue. So there are treatments for it, but they're not always successful because these compounds don't necessarily cross the blood-brain barrier. So you're really stuck. Some kids respond and other kids don't. And I've had the misfortune of dealing with kids who we put on nephrotoxic doses of sodium benzoate only to create one condition in the attempt to treat another. And I've had to back off on treatment, and those kids are lost. So this is often a very frustrating condition, but there are some long-term survivors who do pretty well. Okay. So I'm sort of going through various categories of inborn errors of metabolism, and this one is a kid that I saw a couple of years ago who presented with hypotonia, a very large fontanelle as outlined by these dashed lines here, and seizures. So that was the presentation. And that was suggestive of a particular condition. We also saw absence of the corpus callosum, and we also saw some abnormal calcifications around the knee joints. So this triad made us think of a paroxysomal disorder, and sure enough, this kid has Zellweger Syndrome. So again, not very common, but it represents a paroxysomal disorder. So the peroxisomes are little organelles, sort of like the lysosome, and there are many different enzymatic reactions that occur in the peroxisome, one of which is to synthesize very long-chain fatty acids and to metabolize very long-chain fatty acids. These are not measured on newborn screen. Long-chain fatty acids are, but not very long-chain. If there are more than 22 carbons, they're not measured in the newborn screen. So these are some of the clinical features of Zellweger's: the high forehead, the large fontanelle. We can see cataracts, we can see cysts in internal organs, we can see hepatomegaly, we can see these stippled kneecaps and seizures and absence of the corpus callosum. And these kids do very, very poorly. The defect is in very long-chain fatty acid metabolism. The defect here is in one of a series of genes that actually assembles that organelle, the peroxisome, rather than a particular enzyme activity within it. But if you can't make a peroxisome, you can't sequester the enzymes that belong on the inside. So there are multiple enzyme defects as a result of that. And there's really no good treatment for this, and most of these kids don't make it past the first year of life. So this is an example of peroxisomal disorder. So there are a couple different ways to manage various inborn errors of metabolism, and we talked about the phenylalanine restriction in PKU. We talked about the galactose and lactose restriction in galactosemia. There's something called hereditary fructose intolerance. I think you can figure that one out for yourself. We talked about protein restriction in urea cycle disorders. There's a condition called maple syrup urine disease because of the odor of the urine, where that is a defect in branched chain amino acids, and we restrict those particular amino acids. And you all know about hypercholesterolemia. So there are a number of proprietary formulas that have been concocted over the years to treat particular amino acid disorders and fatty acid oxidation defects and other inborn errors of metabolism. So these are readily available. There are a couple different providers. I don't have a favorite. And there are also pharmacologic management of inborn errors of metabolism. So there's a compound called tetrahydrobiopterin, which can be used to treat mild cases of PKU. It's very expensive. It's an oral agent, though, and it's supposed to make the dietary restriction less restrictive. But it's not for all kids with PKU. So we challenge those kids. We do metabolic testing and challenge them to see who might benefit from this and who might not, because this drug is tens of thousands of dollars a year. We talked about homocystinuria and using betaine and aspirin. We talked about using carnitine supplementation in MCAD deficiency. We talked about sodium benzoate and other ammonia scavengers and arginine for treating urea cycle disorders. Maple syrup urine disease can be treated with one of the B vitamins, as can methylmalonic aciduria. Nonketotic hyperglycinemia we can treat with sodium benzoate. We can actually treat with Valium, which binds to the same receptor. And we can treat with cough syrup, dextromethorphan, usually in combination with these other ingredients. And as I'll get to in just a moment, lysosomal storage disorders, where there is enzyme replacement treatment available. So, but before we get to lysosomal storage disorders, let me just picture this little scenario here. This is a 3-year-old kid lying on his grandmother's ugly couch, failing to thrive, waiting for a diagnosis. So he was worked up by his pediatrician, and he didn't have kidney disease, he didn't have cystic fibrosis. He came to genetics, and he had some very nonspecific symptoms of a chronic disease of some kind. So we just threw the battery at him and found that he had excess methylmalonic acid in his urine. Guess he had methylmalonic aciduria, huh? And on the previous slide, I indicated some of these kids respond to megadoses of vitamin B12. So we shot him up with B12 twice a week intramuscularly, and 3 months later, here he is on the left, thriving, having his picture taken with Big Bird. It's a miracle. It really was. You have to have a clinical suspicion, you have to test, and then you diagnose, and then you intervene. So not all genetic disorders are met with the inability to treat. So here's a very good example of that. And then a couple of years later, here he is on his family's Christmas card showing his toothy smile, continuing to thrive once again. So this is one of our success stories. You catch them early enough before irreversible damage has occurred. So methylmalonic, I don't want to spend too much time on these details. It's just an example of another disorder of branched chain amino acid metabolism, okay? And it's picked up on a newborn screen by mass spec, and we know what the enzyme defects are. Don't bother memorizing them. And some patients do respond to B12. So that's a very simple approach. Now we can get into the lysosomal storage disorders. So I know each of these patients. I've met them over several years, and they're all members of the Big Spleen Club because they all had the same condition. We'll start with this guy up here. He was about 2.5 when he presented to the emergency room in DIC. Christmas Eve. And nobody could figure out what was going on with him, but he had a big spleen, and he had thrombocytopenia, and it was felt that he was sequestering his platelets. So what might be the first disorder that you're thinking of that he might have that's just genetic? Sickle cell. He did not have sickle cell. So now you need to come up with a second one. So my boss at the time was consulted and thought that he might possibly have Gaucher disease. Does he look Ashkenazi Jewish to you? No, he was not Ashkenazi Jewish. But nonetheless, that was the working hypothesis. And on Christmas Eve, we couldn't get an enzyme assay to make a diagnosis inside of 2 weeks. So my boss cajoled the surgeon into taking out the spleen of a child with thrombocytopenia. The surgeon was not joyful about doing that, but the child survived, and we saved his life. And we got the enzyme assay back 10, 14 days later, and sure enough, he had Gaucher disease. As does this little asymptomatic guy here with asymptomatic hypersplenia, and this cute little girl here with the same thing, a large spleen, asymptomatic, and this high school cheerleader here who was complaining that her tummy was too big and she was a little self-conscious about it. Well, it was her spleen, okay? And a lot of these kids will come to hematology first because people fear the worst, that this child has a leukemia or something. But with a normal peripheral smear, at least a seemingly normal peripheral smear, and no other symptoms of a malignancy, Gaucher disease should be in your differential diagnosis. So yes, it's true that in Gaucher disease there is an increased incidence among the Ashkenazi Jewish population, but we also see it in the general population. And none of the patients that I showed you were Ashkenazi Jewish, but again, it was a Tennessee population, not a Manhattan population or a Los Angeles population. It's a recessive disorder. It's a multi-system disease, so it affects the reticuloendothelial system. And there are various degrees of severity, ranging from mild to a neuronopathic form, which is usually lethal. They are all defects in the same gene that encodes the beta-glucosidase, which is an enzyme involved in lipid metabolism, and the treatment is enzyme replacement. So this was the first genetic disorder, the first lysosomal storage disease, which was treated with a recombinant human enzyme made in the laboratory by tricking E. coli into making a human enzyme. And it is now standard of care for Gaucher, and it was the forerunner of a number of other enzymes which have been developed to treat lysosomal storage disorders. So very briefly to recap here, how do we successfully manage inborn errors of metabolism? We have to have an index of suspicion. We have to have early detection before permanent end organ damage occurs. We have to educate the families about the importance of being compliant with whatever treatment regimen you come up with, whether it's pharmacologic, whether it's dietary, or whether it's both. You need to institute that treatment early, and the family has to be very compliant. Some of these special formulas are expensive. Some of them may not be covered by WIC and other programs, so we have to write letters and make sure that these kids get the drugs and the diet that they deserve. And they need to be followed periodically in a metabolic center that's comfortable in dealing with these kids. We really don't expect the primary care provider to be burdened with a child with an inborn error of metabolism, unless it's a trivial one like galactosemia. And then we have to anticipate that some of these kids are brittle, sort of like diabetics. They're healthy 90% of the time, but if they get a little cold, a little fever, a little anorectic, they can crash and burn, especially if they have urea cycle disorders or some of the disorders of energy metabolism. And I want to say a couple words about looking for inborn errors of metabolism in kids with developmental delay or autism. There are a couple papers that I put in your reference guide of studies that have looked at the incidence of inborn errors of metabolism in kids with developmental delay, isolated developmental delay, or autism, and the yield is very low, okay? So it's very tempting for some providers to order tests because they're available, but it's a bit of a fishing expedition, and this is one area where you're not very likely to find something. But bear in mind that not all inborn errors of metabolism are picked up on the newborn screen. So these are some of the postnatal clues that I came up with. I think that testing beyond a comprehensive newborn screen, which is uniform in every state of the country, is best left to either genetics or neurology. So here is this reference that's in your syllabus if you want to read a little bit more about that, okay? So, no big deal. Bart Simpson says it's only a few enzymes, and hopefully I have taken some of the mystery out of inborn errors of metabolism so you're no longer as intimidated, okay? See you in a bit.